the anatomy and biomechanics of foot and ankle. I hope it was useful. And the link will be on YouTube. And the link of this video will be on Mid-All and YouTube as well. So please feel free to stop me if you need. Other than this, keep all your questions in the question and answer section. And Hussam can be stopping me. He will be moderating the session. I'll keep the camera on because, yeah, I have to explain you how I'm going about the gait. So let's start, and just I will share my screen. I got feedback last time that the people wants to keep it for an hour. So I'll do my best to keep it strictly an hour. We may be overrunning for a few minutes, but yeah, it will not go beyond an hour. I'm sorry for the last time because we adapt to do this instructional course for 2 hours every session, but it seems that the people don't like it and they like it to stick to an hour. Okay, good. So you can all see my screen, do you?
Yes, it's clear. Yeah.
Good. Okay. So we will speak today about the gait examination, and if we have a chance, we'll go to speak about planus or flat foot. This is where they come from. Is Heatherwood Hospital. It's an elective hub in Ascot in northwest London, and this is the YouTube channels for myself and for OrthoBima, and the video will be available on both of them once we finish the session. Good. To speak about the gait, and understanding the gait is very, very important. It's not just because the basic knowledge is an important basic knowledge, but as well as it's a way to diagnose a lot of conditions in your foot and ankle clinic. So for the exam, there is good for part A 5 to 6 questions about gait or gait-related problems, and for part B, gait is very important to comment on in the intermediate, and you may have one of the short stations about gait. So gait is so important for all FRCS part A and part B, and as well, it's very important for basic knowledge. It's very important later on in your practice because it's no way to diagnose a foot and ankle problem without understanding what's the problem with the gait. So to understand the gait, we'll speak specifically about these points. So we'll speak about definitions, prerequisites for a normal gait, some biomechanical principles, and we analyze the gait as kinematics, kinetics, and assessment. And then we'll end by common differential diagnosis and examples for abnormal gait. So what's gait? So this definition is very, very important. Gait is an energy efficient translatory progression of your body as a whole due to coordinated smooth movement of body segment. So to have a normal gait, your body should progress effectively in a translation movement as energy efficient as possible with normal coordinated smooth movement of the body segment, depending mainly on eccentric contraction and as much as possible on the ground reaction force. And from here, we can understand what's abnormal gait. So abnormal gait is either it's unsmooth gait, it's energy inefficient, there is poor body progression, or it's uncoordinated gait. So when we speak about the normal gait, we'll go through definitions, prerequisites, biomechanical principles. So to understand the definitions, you need to understand what is step, and with the step, what is stride, and if what's stride, then what the types of movement. Okay. So as you can see from this picture, so a step length is the distance between heel strike of one foot to the heel strike of the other foot. But if we speak about the heel strike of one foot to the heel strike of the same foot, we speak about the stride length. So one step means from heel strike of one foot to the heel strike of the other foot, and one so a step and one stride is the heel strike of one foot to the heel strike of the other foot. Then you have the cadence, which is the rate of your movement, the rate of your gait. Then you have the foot progression angle, which is the angle between the mid-axis of the foot and the normal line of progression. Then you have two phases of the gait: stance phase, when the foot is flat on the ground or touching the ground, and a swing phase, which means the foot is off the ground. So whenever your foot is off the ground, this is the swing phase for this foot. And whenever your foot is touching the ground, this is the stance phase of this foot. Then this movement goes in three directional, as any movement in three planes: axial plane, which is the rotational plane, then rotational plane in the coronal side, and rotational plane in the sagittal side. So rotation sagittally, rotation coronally, and axial movement in the axial plane. To have a normal gait, you have to have a balanced foot. So balanced foot means the foot is flat on the ground, all the muscles and ligaments are working, and the tibia is steady on the talus, and the talus is steady on the calcaneum, and the calcaneum has a normal relation with the midfoot. You have to have a good foot clearance, means you can easily clear your foot while you're walking during the swing phase. If you have any problem with clearing your foot during the swing phase, you will have an abnormal gait. You have to have a normal foot position. So when you heel strike with your foot, then float your foot, then go for a flat foot, your foot is steady on this position, and the position of your foot is normal. You have to have an adequate step length to have a normal gait. You cannot, so jogging or running is different than normal gait. It's not a normal gait, but to have a normal gait, you have to have an adequate step length in a normal coordinated manner, and it must be energy preservative or conservative. This is the idea of a normal gait, or the request is to have a normal gait. So to have a normal gait, you have to have a balanced foot, you have to have a normal foot clearance, you have to have a normal foot position, you have to have an adequate step length, and you have to have an energy conservation. When we start to speak about the gait, you need to understand that for every moment, you have to have a full foot on the ground. How you understand this? When, as you hear striking by, if we suggest this is the left foot, so you hear striking by the left foot, the time you hear striking by the left foot, you're towing off by the other one. So if you calculate what is from your body on the ground, it's a 1 foot, one full foot. When you go to the loading phase and the flat foot, so the whole right foot is on the ground, this means the whole left foot is off. Then it comes to the other side. When the left foot starts to heel strike, then the right foot will be coming off the ground in the two off states and go again for the left foot on the same side, and then the swing phase. So through all the gait cycle, one full foot of your foot will be touching the ground. Either it is a full foot, right or left, or part from the right and part from the left. You need to understand this very well. You touch the ground by 1 foot. Either this 1 foot is one full foot, right or left, or it is a part from the right and part from the left. You cannot heel strike by 2 feet. You cannot toe off by 2 feet. You cannot flat foot by 2 feet unless you are standing. But in a gait, whatever you remove from the left foot, you touch with the left foot in the ground, you remove it from the right foot from the ground, and you walk on a 1 foot. Number 2, the energy reservation or energy preservation. To preserve an energy while walking, you depend as much as possible on the ground reaction force and on eccentric contraction of the muscle. You understand, and all of us know from the basic science, concentric contraction means the muscle shortens, and eccentric contraction means the muscle lengthens. So both of them, the muscle goes into action. If the action of the muscle end by shortening, so we call concentric contraction. And if the contraction of the muscle end by lengthening the muscle, this is an eccentric contraction. And the eccentric contraction of the muscle is an energy preservative way. So the most energy efficient way of muscle contraction is to contract eccentrically based on stopping its lengthening. And to understand, I'm not sure if you know this. So if you go to the bicep curl, with the bicep curl, this is a contraction and concentric contraction. And if something is balling on my hand and the biceps is stopping the lengthening of the biceps, this is called eccentric contraction. So concentric contraction means action or energy of the muscle is to shorten, and eccentric means action of the muscle is to stop lengthening. So when your muscles are acting in eccentric condition, it is preserving energy. Then the ground reaction force is basically as we understand from the third law of Newton, that for every action there is a counter action, which is the same in intensity and opposite in direction. This is the third law of Newton. From the third law of Newton, we understand that when you hit the ground by your foot, the ground will be exerting the same force in intensity and in a different direction. Otherwise, your foot will sink inside the ground. So when you push on the ground by your foot, the weight you put on this side have a similar ground reaction force in the same intensity, but in the opposite direction, as you see on the right side. And this ground reaction force actually has been given to you from the heaven just to make you walk passively. So in any action with the any energy come from the ground reaction force, you don't spend any energy on it. That's why the normal gait is an energy efficient reaction. So like you see, if you heel strike, the ground reaction force is going beyond your ankle. So normally it's trying to plantar flex your ankle. So you plantar flex without spending any energy, because the ground reaction force is doing that for you. At the same time, not to do this aggressively or to slap your foot on the ground. Here, the tibialis anterior will work eccentrically just to keep your foot. Don't allow the foot to lengthen a lot. So don't allow the foot to slap the ground. So to have an efficient gait, you need to understand the three principles. You always walk on one foot. You're walking with energy preservation mode, which means all your muscles are acting in eccentric contraction rather than concentric contraction. And again, concentric contraction means the muscle act is shortening, and eccentric contraction means the muscle stops itself from lengthening, and this is the muscle work. And you depend a lot on the ground reaction force, which is a passive force moving your joints. And this ground reaction force costs you no energy, and it plays the main important driving force in a normal gait. Then you need to understand the foot rockers. Rockers mean the foot where the foot hits the ground. And you normally in a normal gait have 3 foot rockers. Firstly, is the heel rocker. So rocker, this is the first you touch the ground with, is your heel. Then from the heel rocker, your body start to go and move. Then the foot start to be loaded. Then you go to the second rocker, which is the ankle rocker. And then from this ankle rocker, you start go to the third rocker when you toe off, which is the 4-foot rocker. So when you have a look on the left side, the first thing to touch the ground is the heel. The movement at that stage is coming from plantar flexion of the ankle or passively dorsiflexion of the distal tibia. Then the ankle rocker when you load the whole foot. Then the 4-foot rocker when you elevate when you start to toe off and the foot is coming off the ground and all your load is going through the 4-foot. And you lose every rocker in certain pathologies. So with the heel rocker, if you have limited plantar flexion of the ankle, you cannot plantar flex your ankle or you cannot dorsiflex your ankle. When you have an ankle arthritis, you will lose the heel rocker because with heel arthritis, it doesn't allow ankle to go in a passive dorsiflexion and it doesn't allow the ankle to smoothly plantar flex. With limited dorsiflexion and plantar flexion, you will lose the heel rockers. That's why the patient with ankle arthritis will be losing the heel rocker. Then the ankle rocker, you load mainly the whole foot, and specifically when you have a normal arch is the midfoot. That's why the patient with midfoot arthritis is trying to reduce as maximum as he can from the ankle rocker. So the ankle rocker is nearly nothing because he wants to shift from a heel rocker over the ankle to a 4-foot rocker over the 4-foot without loading the midfoot. So the patient with midfoot arthritis will be losing the ankle rocker. Same as the patient with ankle arthritis. 4-foot rocker is when you have any painful 4-foot condition, you try as much as you can to move from ankle rocker to the next foot heel rocker. So you try to shorten or minimize your 4-foot rocker stage. So the foot rockers, the importance of the foot rockers, it gives you a clue where is the pathology in the ankle, foot and ankle. Then when you have a look on the foot unit, you understand that we normally, as we explained in the last lecture, so normally you have some degree of physiological valgus, which goes into varus with the movement. And we have arches of our foot, medial longitudinal, lateral longitudinal, and transverse arch. And if you normally have that, you will have this shape of the foot or foot pressure on the ground. If you have a flat foot or low arch, all your foot will be printing on the ground. And if definitely you have a cavus or high arch, you will be overloading just the tripod, which is the 4-foot and the heel. Then when you look on this picture, you understand that according to the gait cycle, first thing from you to touch the ground is the heel. Then this is the way of the weight bearing. Then the weight bearing goes from this side over the 5th metatarsal, then transferred to the 1st metatarsal head. Then this is how your foot is normally loaded. This pattern is lost when you have an arch flat or an arch high arched. So with any pathology in the hind foot, which is cavovarus or bis planus, both conditions, and bis cavus or bis planus, this condition will be lost, and you will be loading certain points of the foot other than the others. Same if you have some tightness in your calf muscles and you're overloading your 4-foot, this pattern of of weight distribution will not be there. So the normal weight distribution over the foot, starting with heel strike, then move over the lateral border, base of 5th, then go straight to the head of first, And this is how the normal weight bearing happens on the foot in a normal shape, in a normal arched foot. That's why if we go back, that's why we said that you have to have a foot position, normal foot position. Without a normal foot position, weight distribution over the foot or weight loading over the foot will not be that normal pattern, and this is where the problem will happen. The understanding of tibial rotation, we agreed last time that the talus is working as a hinge, which it changed the movement, the axial movement, axial rotation of the distal tibia into a coronal rotation in the foot. And normally you need to understand that with heel strike, when you heel strike, then your foot is bluntly flexing. This foot is going to load, is bluntly flexing. Actually, your tibia is internally rotating. And when you move, all your foot moves to the forward, the tibia continue to internally rotate. At the same time, internal rotation of the tibia equal external rotation of the foot. So the foot, as we agreed last time, with external rotation of the foot and valgus, the chopper joint, the talonavicular ankle kinecuboid, they become parallel in the same plane, and that's why it makes your foot supple, so it can easily accommodate the ground. Once you go to toe off in this stage, when you're toeing off, so your foot is more, your tibia is externally rotating because your foot is internally rotating or adducting. And when the foot is adducting, this gets the talonavicular in a different plane than the calcaneocuboid. Then your foot is rigid. And when your foot is rigid, is a nice lever arm for your body to move. You need to understand this very well. Distal tibia is rotating in the axial plane. Foot is rotating in the coronal plane. When you move, once you heel strike, your tibia start to internally rotate. Your body start to internally rotate, including the distal tibia. Internal rotation of the tibia equal external rotation or valgus of the foot. With external rotation of valgus of the foot, because of the subtalar configuration, as we agreed last lecture, your foot midfoot joint, which is the shoulder joint, will be in the same plane. So the foot will be supple, will be easily accommodating the ground during your loading phase. In this picture, when you go to offload and you're going to toe off, your foot is moving internally and the distal tibia is moving externally. Moving internally of the foot means the foot gets more adduction and more cavus. So the midfoot joint, the shoulder joint, talonavicular ankle kinecuboid will be in different planes. And when they are in different planes, the foot is rigid. That's how it makes a normal lever to make your foot pushes forward. The knee flexion extension is a very, very, very difficult area to understand. Be very, very, very giving me the maximum attention you can. To understand the knee flexion extension, you need to understand that when you heel strike, the ground action force is coming from behind your ankle and going in front of your knee. So normally what it's doing is plantar flexing your ankle and flexing and extending your knee. Once you start to move forward, once your body starts to move forward, the ground reaction force line is fixed, doesn't move. So from the back of the ankle, front of the knee moves forward. So the ground reaction force becomes behind the knee. So from an extending moment to the knee to a flexing moment of the knee, that's why after you load your forefoot, your knee is going to flex. And if you don't have the soleus muscle stopping your knee from more flexion, it will end by you falling on the ground. That's why the soleus is very, very, very important to coordinate your gait, to do what we call knee flexion extension coordination or knee flexion extension coupling, what we call the knee flexion soleus coupling. And that is what's missed in the CB patient. That's why the CB patient always lose their balance and fall. Again, you heel strike. When you heel strike, the ground reaction force is going behind your ankle, in front of your knee, and behind your hip. So at this stage, the ground reaction force is extending for a moment over the knee. Once you flat your foot on the ground and load, and your body starts to move forward, the ground reaction force line doesn't change. It becomes behind your knee rather than front of your knee. So it becoming a flexing moment and aiming to flex your knee. Nothing to stop your knee from flexing until the soleus starts to come into action. If the soleus is weak or not in action, you will continue flexing until you fall. But because soleus, Allah subhanahu wa ta'ala gave us soleus to stop the knee from extensive flexion, so allow you to go to the next stage, which is toe off. That's why you don't fall. That's why your gait comes to be coordinated and normal. And if you lose the soleus for any reason, like you have a CB, and the most common example is the CB patient. If you lose this soleus coupling, knee flexion soleus coupling or knee flexion extension coupling, the end will be that you have to support your knee from the start, or you have to be given a knee brace, knee ankle foot orthosis to stop your knee from flexing more than enough and for you to go with a normal gait. Again, heel strike, moment arm from the ground action force behind the ankle. So plantar flexing the ankle and extending the knee and flexing the hip. Extending the hip, I'm sorry. Once you load your foot, your body is moving forward, distal tibia is moving forward, then the ground action force line is still the same, but the knee now become in front of the ground action force line. So the ground action force line is a flexing moment to the knee. So this makes your knee to flex, and if you continue moving forward, you will be falling. What stops your knee from extra flexion or more flexion is your soleus, which stops the knee from flexion and allow you to go to the next step, which is 2 off. Hassan, if you check the question, this is a very important. These two pictures is the most important again. You will not get it from any like normal reading. If anyone need me to repeat it, I'm happy to do. The tibia rotation and the knee flexion extension coupling. They are very, very important. Any questions?
There's no questions.
Nothing?
Yeah, no questions.
Perfect. That's perfect. Okay. The least and the least important and the least for you to understand is how the pelvis move, but you need to understand it's a very coordinated movement in 3 planes. So the pelvis moves to the front and the back, moves from side to side and rotates. Move from pelvis drops by 7 degrees. You understand this is the idea behind the Trendelenburg test. So every time you move, every time you unload the pelvis by lifting one leg from the side, the abductor on the other side start to move. That's why your pelvis start to drop 7 degrees. Then the abductors pull it back up. At the same time, your pelvis moves 4 degrees anterior tilt and rotates 10 degrees between both sides to make this H-shape coordinated movement of the pelvis to allow you to go with a normal gait. Don't waste your time understanding a lot about the pelvic movement because, yeah, it does nothing. But the patient with hip pain, patient with hip arthritis, patient with spinopelvic problem, like the patient with ankylosing spondylitis or severe ankylosing in the back or spondylitis, they suffer a lot with this movement, and this makes their gait abnormal gait because there is no coordinated simple transition of pelvis movement. But you need to understand that pelvis moves in the 3 plane. So it moves from side to side by the abductors about 7 degrees. It moves to front and back about 4 degrees, and it rotates about 10 degrees on both sides, gives you this normal rhythm of movement, which is like an H shape. If we come to speak about the kinematics of the gait, so when we speak about kinematics, we speak about the movement. We don't speak about the forces causing this movement. So all of us understand that the stance face is the longer face, about 60% of the gait. Swing face about 40%. Stance face starts with a heel strike. Stance face means any part of your foot is touching the ground. Now we'll speak about the right foot, which is in a blue color. Heel strike, then loading response when you put all your foot down. Then from this mid stance, when you stand straight and steady on your foot, then you start to toe off when your body moves forward, and they start, as we agree, flexion in the ankle joint, plantar flexion in the ankle joint, and flexion in the MTB joint. Then from this to pre-swing, then toe off, then from toe off to mid swing, and from mid swing to terminal swing before you hit the ground again with another heel strike. And this is a whole gait cycle, which is stance and swing face. Yeah, all of us and all of you know that. When we come to kinetics of the gait, we speak about the forces moving the gait and how you do this kinematics. And we understand that we start with heel strike. When you heel strike, the ground reaction force is coming from behind your ankle and front of your knee. And by that, it's bluntly flexing the ankle passively and extending the knee passively. And that's why in this stage, your tibialis anterior is working eccentrically. So it's working eccentrically just to stop your foot from slapping the ground. So the ground action force is behind your ankle, trying to move your foot in a plantar flexion, and by eccentric contraction of the tibialis anterior, this means this movement is smooth and easily transition without slapping. That's why the patient with foot drop who has no tibialis anterior function walks with a slapping gait. Every time he touches the ground by the heel, the eccentric contraction of tibialis posterior, tibialis anterior is lost, so the patient easily slaps the ground. From this, the body starts to move, which is the loading force, which is normal, but it works by the inertia. This is the second law of Newton. So the body moves by inertia, so the loading phase happens. During the loading phase, as you can see, this is a ground reaction force line. It was before behind the ankle and front of the knee. Now with the loading force, it become across the ankle and behind the knee. It is a flexing force, and because of flexing force, the quadriceps muscle act eccentrically again just to stop you from overflexion. Once you go to this, you're progressing from this stage to this stage. This is where the soleus starts to act and stopping the progression of flexion of your gait, of your knee flexion, until you go to the mid stance. By the mid stance, you see the ground reaction force become going in front of the and through the ankle in front of the knee, then across the front of the ankle. So it's now dorsiflexing the ankle, and because it's dorsiflexing the ankle, you start toe off, and by toeing off, this time when the triceps suri is acting as eccentric contraction. From this stage, you start to get your foot off the ground, and by getting the foot off the ground, this is where the hamstring start to act, and at the same hamstring concentrically and quadriceps eccentrically until you clear your foot. Then from this stage, you go to the terminal phase when your knee is straight and the line of your weight is straight until you go to the next heel strike. This kinetics, you can find it everywhere. It's not a difficult one. You need just to understand. I always understand it. I never go to it like I don't keep it by heart. I just understand it. Then how can you assess the gait? So there is formal way to assess the gait. So basically, history, physical examination, functional scoring, videoing the patient, which what we call the gait lab or gait lab analysis. And in the gait lab, you video the patient, you take videos for the patient from all the sides. You put some sensors over the muscle, some sensors over the joints, and this gives you an idea about the kinetics and kinematics. And you do an EMG for the muscle to see how much action is happening, how electric action happening inside the muscle. And the end, you do barography, which is you measure the pressure of the foot over the ground. You have some mats and pads of which tests the pressure, where you load your foot and how much you load it. So on the right side, you see the physical examination chart of Alder Hey Hospital in Liverpool. So taking history from the patient, physical examination through a specialized chart like that. It includes functional scoring. Then you go to the gait lab where you video the patient, put some sensors over the muscle to see the kinematics or the movement, and over the joint to see the kinematics, and over the muscle to see the kinetics. Do EMG of the muscle to see the electric changes inside the muscle, and end by barography where you test the pressure points of the foot and where you pressurize the foot. And this is the gait analysis lab in Alder Hey, Liverpool. You see cameras from all the sides. The girl has sensors over the joints to show what movement is happening, which is the kinematics, and kinematics, and sensors over the muscle to take an EMG and show what is the kinetics of this movement. And on the floor, this mat has a barography where it tests the pressure points of the foot, where this girl pressurized her foot. So this is a normal gait. I hope you get a brief idea about it. You understand what's normal gait. You understand what's the prerequisites for normal gait. You understand how your gait to be efficient. You understand the ground reaction force, tibial rotation, coupling, flexion, extension, knee flexion, extension or soleus coupling. Now we'll go to the abnormal gait, and easily to differentiate an abnormal gait in the children. It's maybe habitual, which is like the toe walker or in towing. It could be from pain or trauma, like the antalgic gait. It could be a rotational profile problem like the in-towing, the pathological in-towing gait. It could be a joint pathology like the stiff gait, and it could be a neuromuscular disorder like the crouch gait, the stiff knee gait, and the spastic gait. And it could be a brain injury like the ataxic gait, and it could be neuropathic like the high steppage gait. I will show you an example of every one of them, just a quick video to understand difference between different types of gait in the myopathic gait. So this girl will be walking with an antalgic gait.
An antalgic gait refers to a painful limp.
And basically what she's doing, she tried to shorten the stance phase on the painful side.
And extent weight bearing.
So
specific posturing
She walking with short stance face on the painful side, not to load the painful limb, and this what gives you the picture of antalgic gait. This kid, as a lot of kids we see in the pediatric clinic, is walking with toe walking gait, and then on the right side you will see. Have a look on this kid. What this kid is doing is walking with in-toeing gait, but this is a physiological in-toeing comparable on both sides. The physiological in-toeing comparable on both sides because he has an antiversion, excess antiversion of the femur. This is totally different from the girl on the left. As you see, the girl on the left has very tightness and contraction of the adductor muscle. That's why she's walking with pathological and in-toeing gait. If you see this patient walking, you can see he barely moved the joints. He walked with very, very stiff gait. This because he has a diplegia, spastic diplegia or stiff gait. If you have a look on this girl, when she walks, so she basically have very weakness of the muscle of her muscles of the lower limb. She have weakness of the flexor, weakness of the extensor, and she walks. That's why none of her joints are stable, and this is the crouch gait. Then if you see the gentleman walking, you see that there's nearly no flexion, and this is basically a stiff knee gait. This guy, again, see how is he's walking? So all his muscles are spastic. That's why he walk in a spastic diplegic gait. Look at the gait of this girl, what this girl is doing. So you can see that this girl basically, this girl doesn't clear the right side because she just lean on one side because she has an hemiplegic gait. If you have a look on this guy, like a drunk gait, which is the ataxic gait because of a brain problem. And if you see this nice kid, he's just cleaning his foot by flexing the hip and knee because he have a foot drop or a high steppage gait. And if you look on this guy, you can see he walking with basically waddling gait. He has no support from the trunk muscle because he is myopathic. I hope this part of the lecture is okay. We 40 minutes, so we're nearly on time. I'll go now to speak about the foot and ankle examination. Kindly, if you have any question about the gait before I carry on. Any question about the gait, guys? I'll be so grateful if you all understand this. That's a great success. I'll be a winner. Okay, is it clear, Hassan?
Yeah, it's okay.
No, is it clear or not?
It's okay, but you know that it's not an easy one. So I think we need.
Anyway, the video will be there, and I hope it will be fine. Okay, we'll go for since this may be a question.
Difference between in-toeing and scissoring gait.
A good question, very good question. So in-toeing in-toeing means it's just a rotational deformity. It's just a problem with the rotational profile of the limb. There is no action for the muscle. So basically, with excess femoral anteversion, with excess tibial internal rotation, the patient will be walking with in-toeing gait very smoothly. Scissoring gait means the patient has some spastic pathology with the adductors. So the patient is walking this way. So this is in-toeing, smooth movement because a rotational deformity of the limb with no muscle problem. Scissoring gait, this means the patient has some problem with the adductors. So the adductor is in a spastic position. So the adductors is working uncoordinated movement. So the patient is walking this way. That's why he's scissoring. I think, Kartik, this is clear. So easy way, both of them in toes. The first one in-toeing is in-toeing because of a rotational deformity of the limb. Scissoring is because problem with the adductor, mainly spastic adductors. No worries. Okay. So going back to the foot and ankle examination. So we'll start with the history, and from the history you can spot a lot of the diagnosis. So the site of your pain is very, very important. So if the patient comes to say, I have a heel pain, we have the commonest diagnosis of plantar fasciitis. If the pain of the patient is in the midfoot and it's just vague and burning pain and paresthesia, we can suspect he have a tarsal tunnel syndrome. If the problem is in the forefoot, could be hallux valgus, could be a cloto, could be a Morton's neuroma, could be a Freiberg's, could be a Tarif 2. If the pain has started after an ankle sprain, it may be an osteochondral lesion or OCD. If the pain aggravates on dorsiflexion, it's an anterior impingement or tibiotalar impingement. And if the pain is at rest, so mostly it's not mechanical, the problem is inflammatory, and this happens with a synovitis. If the patient with the pain have some instability, it may be a chronic lateral ligament injury. If the patient has a deformity, you easily can spot the difference between bis cavus and bis planus. And if the patient has complaining of catching sensation in the joint, could be a loose body, could be an OCD, could be some peroneal tendon subluxation, which is a very, very subtle thing and very, very easily missed. If the patient has burning pain and numbness in the toes and he feel like he walk on a stone, this is a characteristic complaint of a Morton's neuroma patient. If the patient says to you, my great toe locks, triggers, and have posteromedial ankle pain, this patient mostly FHL symptoms. If the foot is rigid and has a recurrent sprain, you may think about tarsal coalition, especially if we speak about adolescent or teenager. If the patient has a difficulty wearing the shoes, this is the time you need to look at the toes. With difficulty wearing shoes is mostly a toe problem. With every foot and ankle patient, you need to take a proper history. The main medical history of concern for us is diabetes, rheumatoid arthritis, and what type of management, what type of drugs, and is it controlled or not, and neurological diseases definitely for the clawing and the cavus problem. You have to understand to ask about the social history, especially the smoking. The smoking makes risk of infection and non-union in foot and ankle surgeries the double, which is a very, very worrying and a very, very risky. You have to see if the patient have a social support, because basically after foot and ankle surgery, they will be have protected weight bearing or a difficulty with weight bearing, and they definitely need some support after the surgery. You have to have an idea about the family history, because the hallux valgus runs in families, especially in females. So it comes from mom or aunt to the girl. Then when you examine, we will go, I will show you my system of examination in my clinic. So I start with the patient standing. I have a look firstly around the patient. So I have a look in patient, if the patient using any aids, if the patient using any, what is the shape of the shoes of the patient. You spot a lot from this. The patient with hallux valgus, you will see the shoes has a prominence on the medial side, and the shape of the toe box is not normal. Same the patient which have abnormal loading of the foot, you will see some specific or types of wear and tear in the shoes and in the sole of the shoes. I'll have a look if the patient have any orthotic. I get the insoles out of the shoes and have a look on them, because they give me an idea. If I see like an arch support shoes, you understand arch support insole, so this patient has some problem with the midfoot. If I have a rocker bottom insoles, this means the patient, or rocker bottom shoes, means the patient have a problem with ankle arthritis. Patient if have a Morton's extension orthotics, I understand that this patient may have a hallux rigidus. Then I look generally into the limb alignment. So how the patient stands in front of me, is his shoulders leveled, is his pelvis centered or oblique, and if there's obliquity to which side, if he has a leg length discrepancy, if he has any apparent deformity of the hips, knees, like flexion deformity, varus valgus deformities of the knees, or he has any clear deformity of the ankle and foot. Then I ask the patient to turn 90 degrees to the side, then 90 degrees to behind. So actually I do the side before behind. I should have spotted that. From the side, I look into the arch of the foot. So I have a look on, as you see in this picture, is the arch of the foot is low arch or a high arch? Is the patient is in cavus? Is the patient is in planus? And then from the back, I have a look on the patient, ensure that the patient have the normal physiological minimal 5 degrees of valgus. Ask the patient to tiptoe and see if this valgus goes into varus, which means the subtalar joint is supple. Then from the back, I have a look on the mini two sign, means I can see more than 1.5 toes from the back. This means this forefoot is abducted, and this is one of the pathologies with bis planus. I can spot easily, as you see here, any Hagland deformity or retrocalcaneal bursitis or problems. I can easily spot, as you see, different in the muscle circumference and wasting of the calf muscles, and I can see definitely if the patient has any varicose veins. Then from the front, I have a look on the foot. I have a look on any deformity of the forefoot, any abnormal, any scarring, any abnormal tissues, any abnormal swelling. Commonly to see a dorsal ganglion here around this area. commonly to see a hallux valgus, common to see a hammer toe, to see a mallet toe, to see any splaying lesser toes, to see a bunionate. So easily to spot any of this. While the patient is standing, I ask them to walk to the door and back to me slowly and normal, and I can easily spot what we spoke about in the first half of the lecture about the gait analysis, and if the patient have a specific gait, has he has normal rockers, 3 rockers, ankle, forefoot, ankle, midfoot, and forefoot, or ankle or heel, ankle, and forefoot rockers or not, and how he normally walks. Is he antalgic? Has an antalgic gait on one side, means it's painful for him, and from the gait I can get a lot. Then while he's standing there, I do the Coleman block test, which you see here. And to understand the idea of Coleman block test, the normal tripod of the foot, as I've shown you how the weight bearing goes through the foot. So you load your heel, you load the lateral border of your foot, then you load the head of first metatarsal. And this tripod has to be continuously in normal relation. That's why the problem with the cavus patient is this this part of the tripod, which is the first ray, is dropped down. And because it's dropped down, for the whole thing to be walking normal, the patient get the heel into varus. So you walk on a tripod, which is how the weight is loaded over the foot from the heel, lateral border of the foot, to the head of first metatarsal. And for you to walk, you have this tripod to be at the same level. If one of these tripod has changed, the whole tripod will change accordingly. So with the cavus, your first ray has dropped. So what's happening for the other tripod? The only option is to move this way to get the three points of the tripod in the same level. And that's why the cavus has a varus element. So varus hind foot, cavus or high arched foot, and at the same time adduction of the foot. So because of this, the idea of Coleman block test is to raise the first ray again to normal. Is rather than the tripod this way, it load this normal and see how the foot will correct. If the whole tripod corrects, this means the forefoot was the problem. If the hind of the whole thing hasn't correct, this means the hind foot was the problem. Again, tripod of the foot, heel, lateral border, and first ray or first metatarsal head. If the cavus is forefoot driven, the problem starts in the forefoot. The first ray will be dropped, and because it's dropped, the only way for the tripod to be at the same level is to move this way and make the foot into varus. So what I'm testing, I put something underneath this tripod, trying to get up, allowing the forefoot to drop, and see if the first ray drops, goes to the normal, how will be the situation. And as you can see on this side, once you correct once you drop the first ray, you give it a space from the ground, the whole tripod corrects. So this is the picture of the tripod if the problem is forefoot driven. Once you load all this side, the whole foot position will be normal, and this you know that your cavus is coming from the forefoot pathology. The other way is the reverse Coleman block test, and we do this for bis planus. It's not that common, but you can do the same. The same with bis planus. Bis planus, the arch is flat, and for the tripod to maintain, the arch is flat. That's why this is raised up. The only way is for whole tripod is to go this way. So if I raise the first ray, which was if I unload the first ray, the whole tripod will correct. So this is a Coleman block test, and this is the reverse Coleman block test. Hashem, anyone don't understand that? Hashem?
Yeah, it's okay. You can carry on.
It's clear, yeah?
Yeah.
So once you put your patient on the couch, you look in your normal foot attitude, you have a look on the sole of the foot, and this will give you a lot of ideas because it makes a pedobarography normally for you. It shows you where is the area of callosity, where is the area of overloading. And you once you correct the hind foot, you can see easily what is the deformity in the forefoot. This is the idea of the tripod again. So as you see on the right side, so this patient has a bis planus. So his heel was in valgus. So the deformity in his foot, actually, imagine with me, this is the tripod. Heel went into valgus. So what will happen for the whole forefoot to get the tripod back is to move into supination. That's why when you correct the heel valgus, once you correct this passively, you can see the forefoot supination easily. And the other way in the cavus. So in the cavus, this first ray is dropped. So the whole foot went into pronation. And once you correct the heel varus, you can see the pronation of the whole foot, of the forefoot. So other than your understanding, if you have a look on a flat foot patient, you feel that he is in a heel valgus and pronation, but this is not actually the reality, because to understand the reality of the forefoot position, you have to get the heel back under the tibia. And then at that time, you will realize that the forefoot in the base planus or flat foot is actually supinated, not pronated. Other way around in the cavus, patient in the cavus moves with foot, seems to be supinated, but actually when you correct the heel varus, the whole forefoot will be pronating. Then you have a feel. So you feel for any tenderness, for any bony prominence, you feel for any swelling. Then you do a Jack's test, and Jack's test is actually testing the windlass action of the plantar fascia we explained before. Plantar fascia is attached from the posterior tuberosity here along the central band and the two medial lateral bands across the MTB to the plantar plate of the toe. That's why when you dorsiflex the toe at the MTB joint, you pull in the fascia, and if the fascia is intact, the arch will be maintained, or arch will be formed. I'm sorry. So Jack's test is basically to test the integrity of the plantar fascia. And once you do the windlass action, when you dorsiflex the toe, the whole plantar fascia will be in tension, and that's the time the plantar, the longitudinal arch will be formed. So as you see, patient is flat. Once you do dorsiflexion of the toe by windlass effect across the MTB joint, plantar fascia will go in tension, and that's where the arch will be formed. Then you do the Molter's crack if you're suspecting tenderness in second or third web space because of a Morton's neuroma. And basically, as you can see, you're just holding the lateral rays, you're holding the medial rays, and you just move them against each other. And if this is a neuroma there, you will hear a click, what we call Molter's crack. Then you can feel the Achilles and you can feel the plantar fascia. From the Achilles, you can differentiate if there is an insertional, non-insertional tendinopathy, and if there is a Hagland deformity, if there is a retrocalcaneal problem or bursa or not. Then you have to
There are two questions. I have to give it. So the first question is the difference between leg length discrepancy gait and Trendelenburg gait. And
very good question. Who asked this question?
Hatem Hussein.
Okay. So to understand the difference between leg length discrepancy or short limb gait, you ask about short limb, it's not leg length discrepancy gait. The gait is short limb gait, and the difference with Trendelenburg gait. Come with me. What the Trendelenburg is, basically, I have to have the free body diagram of the hip to understand this. But imagine with me, you have your pelvis, your two abductors on both sides, and your foot on the ground. Okay? This is the right side, this is the left side, this is the abductors, this is the pelvis in the middle. Imagining with me. When you get the left foot off the ground, what normally happens, the pelvis will drop on the left side because there is no support. Yeah? That's the time when the abductors on the right side will pull the pelvis back and make your pelvis balanced. If you have a problem with these abductors, what will happen on the right side? If your abductors on the right side, myopathic, weak, injured, has a superior gluteal nerve injury, whatever the cause, abductors are not working. So every time you get your left foot off the ground, the pelvis will drop on the left. And for you to correct this, you have to move all your trunk to the right. Because if you remember the free body diagram of the hip, the center of the hip is the center of rotation. Abductors with lever arm on one side, and weight of the body and lever arm for the weight of the body on other side. And these forces should be in equilibrium for the pelvis and hip to maintain steady in place. If the abductors are weak, so the only way for you to manage this is to move all your body toward the hip. So shorten the lever arm of the body weight, and this gives the abductor less function to do. And you try to minimize the function the abductor or the force the abductor needs to generate because your abductors are weak. Again, two abductors maintaining the pelvis in place. If the abductor is normal, when you get the left foot off the ground, the right abductors will be contracting, so getting your pelvis to be straight again. If abductors are weak, you try to lean your body toward the problematic or pathological side to minimize or shorten the moment arm of the body weight, which gives enough less function for the abductor to do, less force for the abductor to do. So you help your weak abductors. So the patient, when the patient walks, you see the patient pelvis drops on the left and shoulder drop on the right. Pelvis drop on the left because no support, and then shoulder drop on the right because you lean by your body toward the pathological side, just to shorten the lever arm of the body weight, to ask the abductor to do less force, so less work for the abductor. So with the Trendelenburg gait, you pelvis drop on one side and the shoulder lean to the other side, which is different completely from a short limb. On a short limb, your short limb is the left limb, okay? When you walk with short limb on the left, every time you put your foot in the ground, pelvis and shoulder drop on one side. So if you have a look on the patient from the back, the patient with short limb gait will be walking with shoulder and pelvis dropping on one side, while the patient with abductor deficiency or Trendelenburg gait will be walking with pelvis dropping on one side and shoulder dropping on the other side. If your pathology, if your short limb is the left limb, you will be walking with shoulder and pelvis dropping on the left. If you have a pathology on the right side abductors, you will be walking with pelvis dropping on the left and shoulder leaning to the left. I hope this is.
Yeah, thank you. Another question: is a jack lift-off test for flexible bis planus the same principles as a reverse Coleman test?
No, so reverse Coleman is different. So reverse Coleman for every and each four-foot driven base planus will be correcting. Jack's test can be negative if the foot is a midfoot is rigid, so the arch cannot be recreated. If the plantar fascia is ruptured, if the patient has a first MTV pathology, a lot of pathology. You need to understand the mechanism behind every test, and easily you can do it. This is the tripod. Bis planus means if four-foot driven means that the first ray is dorsally flexed. So for the whole tripod to work to do the action, the whole tripod needs to go this way. So when you raise this from the ground, so no loading of the first ray, the whole tripod will be correcting. This is the reverse Coleman. Jack's test, your fascia, your plantar fascia is going from the calcaneal tuberosity all the way to the first MTB, then it goes to insert into the plantar plate. Every time you push your toe in dorsiflexion, you tension the plantar fascia, and the plantar fascia, if tension means it shortens, and the only way to shorten is to create the arch. Jack test will be, reverse Coleman will be positive if the problem of the base planus is coming from the hind foot, but Jack's test will be positive in a lot of conditions, stiff midfoot, like severe arthritis, so arch cannot be recreated, plantar fascia pathology, first MTB pathology or hallux rigidus, plantar plate ruptures, a lot of pathologies.
Okay. Can you repeat the tripod again?
So tripod, as you remember, how the foot gets the load on. Heel moves to the lateral border, then the ball of the first ray or ball of the first metatarsal. Okay, this tripod should be on the ground all the time at the same level. Okay, what's happened with the cavus? The forefoot, the arch is high arched. The arch is exaggerated. Yes, means that the forefoot means that the first ray has dropped more. Yeah, it's like that. How we can get this tripod to be normal again? You move the tripod, whole the tripod is there. So heel goes into varus and forefoot goes into pronation. Okay, tripod back. This is the normal tripod. What's happened with the base planus or flat foot? The first ray is dorsiflexed, so the arch is low. Yes, for this arch is low to be corrected, for this tripod to go normal, the whole thing has to go in valgus. So valgus, hind foot, and supination of the forefoot. What you do in Coleman block? You load this tripod, you correct this tripod, you free. What you actually do, you free the first ray. So first ray is not loaded. You just normally load the other parts of the tripod. So if the problem is just from the forefoot, which you unloading with the Coleman block, the whole tripod will correct. This gives you an idea that the problem was in the forefoot or the first ray, and once you get it off the ground by putting something underneath the lateral border of the foot, the whole thing is correct. Tripod, drop first ray in base cavus, the whole thing to correct has to go this way to be in the same ground, and the other way around if base planus. If we go to the neurovascular examination, we aim to finish on time. If we go to the neurovascular examination, you have to do a proper neurovascular examination because big part of our practice is diabetic foot or neuropathic foot. You have for neurovascular examination to ask if a normal patient, you ask just about the spine. Do you have back pain? Do you have any neuropathy or weakness? If not, ignore the spine and go and examine the periphery. You examine the periphery for light touch and bone break, and you test for if you need to test for any sensory deficit. Use a 10-gram filament, what we call Simpson-Weinstein filaments. It's 10 grams. Is available in every foot and ankle clinic, and the idea of this is 10 grams in weight. When you push a certain point, if the patient doesn't feel it until you bend the filament, this means this patient has a neuropathy, and we put it into Gait. Normally, if you give it to a normal person, once you touch it with 10 grams, the patient will feel it. If you touch it with 10 grams and patient doesn't feel, means he has some degree of neuropathy. You start push, and the filament will be bending. And this gives you an idea how much neuropathy does this patient have. And 10 grams, this is a specific, you need to remember it. So if we come to the distribution, we understand that the saphenous is covering up to the middle. The fish is covering the dorsal the first space, which is covered by deep perineal, and the lateral border covered by sural. Then if you go from underneath, you have this area, the area number 6 is covered from behind by the posterior tibial, from the outer side by the sural, from inner side by the saphenous. Then the medial plantar covering the medial 3.5 toes, and the lateral plantar from the posterior tibial or tibial nerve is covering the lateral 1.5 toes. Then the movement. So movement, you have in a foot and ankle examination, every patient has to have a Batten score. You need to see if the patient has any ligamentous hyperlaxity or not. Batten score is a score from 9. I'm sure all of you know it. If the patient has 5/9 or more, this means the patient is hyperlax. And this score is invalid in the kids because the kids is hyperlax. So don't use it in the kids. It's a very tricky point in the exam. You test the active and passive range of motion of every joint. Firstly, the ankle joint, and while you're testing the ankle joint, you do a squeezing test. And the squeezing test, basically, you understand that the tibia is behind the fibula, and you put your hand over the fibula and the thumb over the fibula and the 4 fingers over the tibia, and you start to squeeze to assist the syndesmosis. If the patient has any pain in the syndesmosis, this gives you an idea that the syndesmosis could be injured. Then anterior impingement test, as you can see on this side, you ask the patient to keep the toes against the wall and to bend the knee. Then you ask the patient to move back and bend the knee, and this gives you an idea how much the patient can move, can dorsiflex the ankle actively. And this gives you, if the patient is in pain in this position, means there is some tibiotalar impingement anteriorly. Then you ask the patient to move the subtalar, and to move the subtalar, he has to move the foot in and out to do a pronation, supination, not inversion, eversion. But ask the patient to move up and down, this is the ankle. Ask the patient to move in and out, this is the subtalar. And for you to test the subtalar, you have, as you see on this right side again, you have to stop the ankle from moving and just move the hind foot. Because if you move the hind foot without stopping the ankle, the movement of supination, pronation has some contribution from the ankle. So to test the subtalar specifically, you have to stop the ankle by fingers or by hand or whatever, and test the hind foot, how much the calcaneum moves over the talus. Then to go to the shoulder joint, and from the shoulder joint and the wrist phalanx joint, and then you ask the patient, you stress the forefoot in adduction, abduction to stress the shoulder joints. Then you test for Achilles tightness, as you see here, to ask the patient. You try to see how much the patient can passively dorsiflex in knee extension, and then ask the patient to bend the knee and see if the patient dorsiflexes more with bending the knee. This means Silver's coil test positive. This means that the gastrocnemius is tight, and once you flex the knee, you get the gastrocnemius out of the equation, and that's so the tendon, Achilles, and soleus are okay. But if you put the patient in knee extension, dorsiflexion is limited, and when you bend the knee, it is still limited, means the whole complex is contracted, and this Silver's coil negative. Then don't say Silver's coil positive and negative because it's differently interpreted everywhere. Just say that this patient can passively dorsiflex in knee extension up to this, and in knee flexion up to this. And anyone who read it, he knows that if the knee extension, if the dorsiflexion, passive dorsiflexion in knee extension is less than knee flexion, this means the gastroc is contracted and the tendon, Achilles, and soleus are okay. If the patient has limited passive dorsiflexion in both knee extension and deflection, means the whole complex is contracted, and this makes a huge difference if you plan to do an operation. So if the patient have a limited passive dorsiflexion in both extension and flexion, there is no point to do a gastric release. This is the point to do a lengthening of the Achilles, because the whole complex is contracted. But if the patient has limited dorsiflexion in knee extension, and once you flex, the passive dorsiflexion improves, this means the gastroc is short or contracted, and this is the time you do a proximal gastroc release. Then if you have any deformity, you have to check where the deformity comes from. You may not be able to do this by inspection only. You need to check if the deformity you have is flexible or not. You have to check if the deformity you do is correctable or not. And then with the hallux rigiditas or arthritis of the first MTB, you can do the grinding test to confirm if the patient has a hallux rigiditas or not. Then you earn your examination by stability, and testing the stability you test in anterior drawer and varus inversion. And we agreed last time, anterior drawer, to do it, we testing the anterior tibiofibular ligament. We put the ankle in plantar flexion, patient knee is bended to relax the gastroc, ankle is in plantar flexion, and I do just anterior drawer. And if I want to test the posterior tibiofibular, I just do the same but in dorsiflexion. While in varus inversion, we're testing the calcaneofibular, so both the ankle and neutral, knee is bended, and then you do varus inversion. Then you finish all this by testing the tendon. You need to test tibialis anterior, which means you're testing the ankle, the foot, while the ankle is in plantar flexion and trying to invert. Tibialis posterior, ankle in dorsiflexion and trying to invert. Peroneus longus, ankle is in plantar flexion and trying to invert. Dorsiflexion and trying to evert. Peroneus brevis, ankle is in plantar flexion and trying to evert. This is how to test the 4 tendons. If you cannot see any problem, you have to think about something subtle, is not clear in your clinical examination, which should be as the osteoarthritis, instability, or hallux rigidus. Then have a look on the shoes, as we agreed from the start. Remove the insoles. Describe, is it accommodative or corrective? There is heel wedge, if there is arch support, if there is Morton's extension, whatever. Have a look on the sole of the shoes and ensure if this is normal wear pattern or this area is more worn than the others, and if there is some build-up wedges has been put in, if there is custom-made shoes or not. Have a look on the hand if you're suspecting the patient has a rheumatoid arthritis or hereditary sensory motor neuropathy or Charcot-Marie tooth. And have a look on the spine if the patient has back pain or any history of a spine problem, especially in young adult. You need to exclude any spinal dysraphism, spina bifida, or any spinal surgery. Are we okay to guess with bis planus? It will take good 15 minutes. Guys, write me with me in the chat so we can keep the bis planus for the next time. If you are happy, we can go ahead. Guys, shall I go ahead? Okay, good. So if we speak about bis planus, I'll try to be quick. So you understand bis planus is actually a base plano valgus. Okay, so you can have cavus without varus, but you cannot have a planus without valgus. So bis planus is bis plano valgus foot, and as you can see, is 3 component: is flat arch in the midfoot, is valgus in the heel, and it is supination of the forefoot. And this comes to the tripod the point we explained before. So what you will find in the history in a flat foot patient, the patient will be coming to complain from a lateral heel pain, and this is very common complaint. And to understand this, you have to look on this picture. As you can see, because the heel is in valgus, the patient will have some subfibular impingement here, and that's why the patient will be complaining of pain on the lateral side. If the patient complains from pain on the medial side, either this patient has a tarsal coalition medially, or because of the stretch of the medial structure, including the deltoid ligament. Okay, so the patient will be complaining from lateral heel pain because of subfibular impingement, or medial heel pain, medial side pain because of stretch of medial structure. From the history, you cannot spot if the patient is a child, so the commonest cause is coagulation, and you have to check that unless it is flexible. And if in adult, you have to suspect firstly that this patient have a tip post insufficiency before anything else. From the medical history, you need to know if the patient is diabetic and neuropathic or not. If the patient has a rheumatoid arthritis, means all the soft tissue structures are weak, and you need to spot if the patient has a hypermobility, and this is idiopathic for him. Then on examination, you definitely has to have a look on the shoes. You will see that the medial side of the shoes is worn more than the lateral side because the patient walking in valgus and loading the medial side of the foot more than the lateral. You have to look on the gait, and easily you can spot that the patient, because what is due the plantar flexion and inversion is a tibialis posterior, and if the tibialis posterior is weak, you will find that this patient has a reduced plantar flexion during swing phase. You will see that the patient has a hindfoot valgus and again collapsed medial arch and a forefoot adduction, which you spot from the back while looking in the patient from behind as a 2-mini-2 sign, which means 1.5 toe is seen from behind. You ask this patient to do a double hair rise, and double hair rise, you need to understand you're just looking into the subtalar joint to see if it's moving or not. So you compare, normally you have the physiological 5 degree of valgus on a stance, and when you walk or when you stand tiptoe or you double heel rise, your normal heel, if the subtalar is supple, the both calcaneae will go into varus. If this happens, this means the subtalar joint is working. And why was double heel rise? Because even if he has a tibialis posterior insufficiency on one side, the other side will be helping the body to go on tiptoe. And once it goes in tiptoe, if the subtalar is supple, both heels will go into varus. So you're doing a double heel rise just to ensure that the subtalar joint is working and supple. The single heel rise test is basically to test the tibialis posterior tendon. And you cannot test it once because sometimes the tibialis posterior is not absent or ruptured, but it's actually weak. And to get the weak muscle to explain itself, you have to repeat this heel rise at least 5 times, or ask the patient to go in a tiptoe and stay there for like 20-30 seconds. Because he can do a single heel rise quickly and we're done, and you say, oh no, I've tested the tibialis posterior, the patient is doing doing a heel rise normally. But to spot a weak muscle, either to ask him to do a heel rise or tiptoe for a while, like 20-30 seconds, or ask him to repeat the single heel rise for a weak tibialis posterior to express itself. Then you can examine the tibialis posterior itself, as we explain again. Ask the patient to invert in plantar flexion. Then assess the subtalar and ankle movement. Is it fixed or flexible? Assess for gastrocnemius tightness, and I will explain to you why gastrocnemius tightness or tendon or Achilles tightness, why you must comment on cervical coil test in every flat foot patient, because the Achilles is normally a valgusing force. So the Achilles will be always tight in bis planus. So, and this will be part of your correction if you plan a surgical correction for a bis planus. You do a JAX test again to ensure that your midfoot is flexible and the plantar fascia is intact, as we explained. You have to have a thorough neurovascular examination to ensure that you don't have any area of neuropathy. Then we speak about very important point, which is the pathoanatomy and pathophysiology. So the pathoanatomy is, we understand from the anatomy is that the calcaneum is not directly under the tibia, and as you can see here, the subtalar axis is just lateral to the mid line of the tibia. Number 2, you have 3 arches. We agreed before that the medial arch, the keystone bone here is the navicular, is maintained in place because of static and dynamic stabilizer. The dynamic stabilizer are the tibialis posterior and the plantar fascia, and the static stabilizer is the spring ligament and the interlocking between tarsal bones. Lateral longitudinal arch, it depends on the shape and the shape of the lateral rays, the 4th and 5th ray, and is maintained by the lateral ligaments. Then the transverse arch is maintained by peroneus longus and interosseous ligaments. The pathophysiology is, you understand that bis planus in normal adult, if they doesn't have a bony problem or tarsal coagulation, it happens because of tibialis posterior failure for any reason. And with tibialis posterior failure, we agreed from last time that there is groups of muscle working in accordance or in coordination. Tibialis posterior with peroneus brevis, tibialis longus with peroneus longus. Once the tibialis posterior fail, the peroneus brevis takes predominance, and that's why there is the forefoot, the hind foot goes into valgus, the midfoot goes into plantar flexion or dorsiflexion or flat arch, and the forefoot goes into abduction. If we go and remember, the tibialis posterior function is to plantar flex the ankle, invert the hind foot, and adduct the forefoot. When we lost this, the ankle is easily going in dorsiflexion, the midfoot is flat arch, the hind foot is in valgus, and the forefoot is in abduction, because the counteracting muscle, which is the peroneus brevis, is predominating over the feeling or the weak tibialis posterior. Again, as we understand, because the subtalar axis is just lateral to the midline of the tibia, that's why the Achilles tendon in its normal situation is a valgusing force. It's aimed to go this into valgus, and when the patient is in valgus or base planus, the tendon Achilles goes to be short and tight, and this is maintaining the position of the base planus. That's why you have to lengthen the Achilles before you do anything for your flat foot. At the end stage, a lot of valgus, heel valgus, a lot of stress on the medial structure, deltoid start to be insufficient, and this gets you to grade 4 BTTI or posterior tibialis tendon insufficiency. And this is when you have to do something for the ankle, not only the hind foot and forefoot. What's the etiology of base planus or flat foot? It's either congenital, like a vertical talus, like a tarsal coalition, which is very, very common in children, spina bifida because of weakness of the muscles, and CB. Acquired, the commonest cause in adult is tibialis posterior insufficiency. Rheumatoid, definitely because it deformed the joints. Polio, because of weakness of the muscle. Degenerative, like arthritis, especially in the hind and midfoot. Or could be iatrogenic because of failure of correction. It's very common to happen with failure of correction of clubfoot. If you do a poor pulsati technique, or you do overcorrection, you will end by a rockering foot, which is a form of flat foot. It could be physiological. Yes, most of the kids in the early year of life, first year of life, they are normally physiologically like that because they have flat foot because of a lot of fat underneath the arch. It's actually not the arch itself is flattened, but there's a lot of fat underneath it. That's why if you have a look in your kid which is less than a year, you will find most of them are flat foot physiologically without any problem. Could be flexible because of ligament deficiency. The commonest example for this is Ehlers-Danlos syndrome. It could be a normal variant. Yes, if you look in a lot of patients, you'll find them flat without any pathology. Tibialis posterior function, joints are supple, but they are physiologically flat. As I told you, 40% of the patient born with flat feet, and 10% of the patient are flat at 10 years. How to assess an X-ray for a flat foot? You have to look on a weight-bearing X-ray, or what we call the foot series. So foot series is EB lateral oblique of a foot while patient is standing. Why standing? Because you need to see the actual situation of the joints in your normal day when they are loaded. The first thing, you look from the front, back to front, or front to back, whatever you want. You have to look firstly on the forefoot abduction, and you can spot the forefoot abduction by looking into the tibiotalar cover. Normally this tibionavicular cover, normally this navicular should be here. So the axis of the talus should be going with the axis of navicular and first ray. But as you see, the axis of the first ray and the navicular is there, and the axis of the talus is there, and there is all of this uncovered is about 40 degrees. Or we can calculate this rather than this angle, calculate how much of the talus is not covered by the navicular, and as you can see, it's about 50 to 60% uncoverage. This means severe forefoot abduction. So first thing to look at is the forefoot abduction, and to look at the forefoot abduction, either you calculate the angle between the longitudinal axis of the talus and the line of the first ray with the navicular, or to calculate it with how much of the talar head is not covered by navicular, and is this uncoverage is more than 15%, which speaks about significant forefoot abduction. After this, you go behind. This is the midfoot. You go to the hind foot, and the hind foot from the EB, you can spot what we call the kite angle. So if you see, it's like if you complete these two limbs, it's like a kite, and the kite angle is between the longitudinal axis of the calcaneum and longitudinal axis of the talus. And as you can see here, it's more than 35 degrees. This means this heel went into valgus. Then you can easily spot. Oh, sorry. You can easily spot from this side from the lateral side, the Meres angle, which is the angle between longitudinal line, longitudinal axis of the talus and longitudinal axis of first ray and navicular. And normally these lines should be either parallel or within 3 to 4 degrees from each other. If this angle, Meres angle, is positive, this means this is a cavus. If negative, this means it's a planus. So as you can see, so yeah, if the Meres angle goes less than 4 degrees, means it's going into negative. This means a planus. If it's increasing, means it's a cavus. Then you spot the calcaneal pitch, which is a line tangential to the inferior edge of the calcaneum and the ground, and this normally about 16 degrees. And if this calcaneal pitch is decreasing, means this foot is going to be flat. There is the arch, the lateral longitudinal arch is not there anymore, and this gives you an idea that this is a planus. Then it's very important to have an oblique views, because you can see what we call antiteter sign, where antiteter sign means calcaneo-navicular correlation or abnormal connection. So antiteter sign means abnormal connection between calcaneo and navicular, or calcaneo-navicular correlation, which is the commonest form of correlation. So if we speak about the adult, as we agreed, the most common cause of flat foot in the adult is tib post dysfunction. It's the commonest cause of adult acquired flat foot. Actually, it's not because the tendon is weak or something, but the tendon is degenerating, because we agreed last time that the tendon is angling behind the lateral medial malleolus 90 degrees. And because of this makes some watershed area here with low vascularity and easily degenerate. And when it degenerates, the tendon is not function normally again. So there is no more hind foot inversion or forefoot adduction. And this is when the patient starts to have a flat foot, heel valgus, and forefoot abduction. Dip post is normally coming, from the back of the tibia, fibula, and the interosseous membrane. It goes to insert into every bone in the midfoot except base of first metatarsal. So navicular, Q3, coeniformis, cuboid, metatarsal from 2 to 5, sustentacle antilli. So every foot in the tarsal and mid-tarsal, tarsal and mid-tarsal and hind foot except base of first metatarsal. The function again, so it plantar flexed the ankle, it inverted the hind foot, and it adducted the chopper joint, and is definitely the most important dynamic stabilizer of the longitudinal arch. This is Johnson and Strom, which has been modified by Merson. So Merson has modified this, added the stage of what we call deltoid ligament insufficiency and ankle valgus. So as you can see, basically you can differentiate it into 4 stages. Stage number 1, which there is no deformity, it's just the tendon is painful and there is tenosynovitis. There is nothing in the radiograph, that the foot is normally plantigrade. Stage 2, which is flexible flat foot. Stage 3, which is rigid flat foot. And stage 4, when the ankle starts to come into the equation. So stage 2, we classify into A, B, C. So from stage 2, there is a deformity, but in stage 2, it's still flexible. In stage 3, it is rigid or fixed. In stage 2, the flexible deformity, number A, the hind foot only, but the midfoot and forefoot are normal. Number 2 means the forefoot start to abduct. Number 3 means the midfoot come into the equation and the forefoot is abducted and supinated. Stage 3 is a hind foot rigid deformity, so it's fixed, no movement anymore. And stage 4, where Merson had added, is when the deltoid ligament become compromised and the ankle itself goes into valgus. How to manage the tib post dysfunction? So it depends on the stage. You have to start with conservative routes, which in the form of some support, arch support orthotics, some stretch exercises to the tendon and for the calf muscles, some resting, some ice, if the tenosynovitis is evident, some pain management. You have to start with this. You have to exhaust the conservative measure before you do anything else. If you're still in stage 1, all what you do is to rest the tendon until the tenosynovitis improves. So insoles with arch support or heel wedges, ankle foot orthosis, tib post debridement in case that it's severe tenosynovitis and severely painful. You can go arthroscopically, so there is tib post arthroscope to go and debride the tendon. If we speak about the stage 2, and stage 2, that as we agreed is a flexible deformity, you still again try non-operative treatment in the form of orthotics, longitudinal arch, hinged ankle foot orthosis. And at the stage after that, if your problem is in the hind foot, you can do a medializing calcaneal osteotomy. If the problem goes to the supination of the midfoot, you can do FDL transfer to the tendon to tibialis posterior. So you get the FDL tendon to do the job of the tibialis posterior. You insert the FDL into the navicular, so it does the same job at the tibialis posterior. And at the same time, you can tighten the spring ligament, so act on the spring ligament anti-post to correct the deformity of the midfoot. And definitely, as we agreed, every surgery for the flat foot, you have to lengthen either the Achilles or to do a proximal gastroc release according to your cervical coil, is it positive or negative. If you plan to correct intraoperative, this is your order of correction. You firstly starting with either gastrocnemius release or a recession or tendo Achilles lengthening, depending on the cervical coil. You correct the hind foot, so you go in order. So you correct the hind foot by medializing calcaneal osteotomy, which gets your calcaneum under the tibia. So correct the line of the axis of your hind foot. Then after that, you have the option to do an arthroresis screw. I'm sorry, this is mistaken. It's not arthrodesis, arthroresis. Arthroresis means you put a screw in the sinus tarsi, which moves the whole subtalar, maintain the whole subtalar into varus. So correct the heel valgus, and you keep it for some time until all the tissues start to scar and you get it out. It's not a very common practice at the moment, but was very common practice in the old days, and it's still a common practice in beads. Then you do either a tip post reconstruction if you can. If not, you do an FDL transfer to replace the tibialis posterior tendon. You do a spring ligament repair to shorten the spring ligament. You take a piece from the spring ligament and tighten the spring ligament so you can get the whole arch back to normal. And if you still have a problem with the forefoot, you can do a lengthening of the lateral column by Evans osteotomy, either through the anterior posterior of the calcaneum or the cuboid. Or you can blunter flex the first ray through a Cotton's osteotomy. So basically, you antagonize the deformity, the deforming force. Then, if the patient have arthritis, so the only option is to do a fusion. If the joint is arthritic, there is no point to do any reconstruction. If we go to stage 3, deformity become rigid. So the option we have is to do fusion. We try to be as conservative as we can. So if we need to do a double fusion, that's fine. If we need to do a triple fusion, that's fine. Double. So basically, you have 3 joints: subtalar, talonavicular, and calcaneal cuboid. You may be fusing 2 of them or 3 of them. And if we go and stage 4, when the ankle become in the equation, you have an option, if the ankle is not badly arthritic, to just lengthen your Achilles and do a deltoid ligament reconstruction. If the ankle become arthritic, you have to combine the triple fusion with an ankle replacement. If we come to the commonest cause of flat foot in pediatrics, so tibialis posterior dysfunction or PTTI, posterior tibialis tendon insufficiency, is the commonest cause in adult. If we come to flat foot in pediatric, the commonest is tarsal coalition. And in simple terms, tarsal coalition is failure of differentiation of the tarsal bone, so the tarsal bone maintain fused when they should not be. It could be just fibrous coalition, cartilaginous coalition, or osseous coalition. Patient will come to you with a complaint of recurrent pain and sprains. So it always becomes symptomatic when the patient the normal joints, the normal bones start to grow as normal, and then that's why ligaments become more stiffer. So the patient should have the movement from a normal joint, but because the joint between the tarsal bone is not normal and the tarsal bones are fused, patients start to be symptomatic with pain or recurrent sprains. Patient sometimes is painful over the tarsal coalition side because it's weak, bony, or fibrous or cartilaginous. Or sometimes if the tarsal coalition is bony, patient doesn't complain from the side of coalition, but complain from the malalignment of the whole foot. To examine the patient, normal examination of any flat foot, in tarsal coalition, you will find that the flat foot is rigid. So whatever the patient do a heel rise, the heel doesn't correct from valgus to varus because it is rigid and the subtalar is not supple anymore. The types is either calcaneonavicular or talocalcaneal. The commonest is calcaneonavicular. 90% always become symptomatic at an early age, so 8 to 12 compared to 12 to 16 in talionavicular. As you see, as we said before, anteater sign in anterior process calcaneum start to be fused with navicular, or if you have a talocalcaneal coalition, you will see what we call C sign. So this patient, if C sign, you can spot it easily. You differentiate. This is normal. This is C sign, and this is if you have in the tarsal coalition, it's actually C sign here as well. So they are both C sign. He just marked it. And here you say anti-teeter sign. CT is a must. You have to have a CT to understand the bony coalition. Is it how much of the joint between the tarsal bone is having a coalition? Could be a whole whole surface is collated, or just part of it, and this will differentiate. Will come to an in account when we go for surgical treatment. Then, if you are not sure about the tarsal coalition as a bony one, you have no way to get a better idea about fibrous or cartilaginous except if you do an MRI scan. Your treatment, again, you will exhaust non-operative treatment, stretching by physio, heel inserts, immobilize, and if no option, you have to operate. In this point, I know it's beyond you a bit, but you need to understand that you operate based on the symptoms of the. If the patient is symptomatic from the malalignment, so you aim to realign the hind foot and the forefoot. If the patient complains from the tarsal coalition side, this is when we speak about how much coalition is there. So if the patient complaining from coalition side, I will have a look in a simple terms. If the coalition is less than 50%, so I will go resect the tarsal coalition and put some interposition there, either tendon, either fat, just to get the joint moving again. If the tarsal coalition is taking more than 50% of the joint, so there is no point to reconstruct. It's easier to make this coalition into a complete fusion or arthrodesis, so the patient is away from pain. So again, if the patient is painful over the tarsal coalition side, you will deal with the tarsal coalition according to the CT. If less than 50%, so I will take the coalition off, maintain the joint, supple again, put some interposition with fat or tendon. If the tarsal coalition is more than 50%, I will complete it to a complete arthrodesis or fusion. If it's more than 50%, it's definitely worse prognosis because these are very young patients. Our approach, if we are approaching a talocalcaneal, we go from medial. If we are approaching a calcaneonavicular, we go from lateral. And this is some of the common questions in MCQ in part 1. Thank you so much. I couldn't make it shorter than this. I need to help you finishing the whole course in a good time before your exam. That's why I'm a bit I'm taking time. I'm sorry for that, and I hope it was a useful lecture. I'm happy to get any question. Why? Sorry, I just stopped sharing. Stop. Yeah. Ahmed is asking why coalition gets frequent sprains. So basically, it gets frequent sprains because there is one joint is not moving. So if you walk, normally you walk through all your joints. So ankle, subtalar, and midfoot joints are all working. Yeah. If I stop your subtalar joint, I put more stress on your ankle joint, and the main function of the subtalar is to accommodate the ground and walking. If you don't have this accommodation of the ground and walking, this puts varus or valgus stress on your ankle. That's why this patient is always having a sprains. Again, for you to normally walk, you have to have a supple ankle, subtalar, and midfoot joints. And the most important in the walking is the subtalar because it allows you to accommodate the ground you're walking on. If you have this subtalar fixed or fused or coalition, this means the subtalar is not working. So you're stressing the ankle and the midfoot more than normal. Added to that, you cannot accommodate the ground by your subtalar as normal. That's why you need to accommodate the ground by your ankle, which moves your ankle into varus or valgus stress. That's why this patient comes to you always with a complaint of frequent sprains. Any more questions, guys? More questions? Okay. I hope it was useful. The video will be available on Mid-All. Please put your feedback once you get the link. You should have got the link by now. So once you have the link from Mid-All, put your feedback. I'm accommodating all positive and negative feedback. All your feedbacks will be taken into account. This will help me to modify the next sessions. Next Friday, unfortunately, I will not be there because we have the Egyptian Orthopedic Association Congress in Egypt. So we'll be off next week. Then we'll be back in the week after. Kartik, thank you so much. Yeah, I ask just put your feedback when you have it, and yeah, you're always welcome. Guys, very good luck. Have a look on the video, understand what you need to understand. Again, it's my mobile number and my email. If you have any questions which you didn't get a chance to ask, I'm more than happy to receive your question either by phone or by email. And yeah, wish you all the best and have a good evening, and we'll see you in 2 weeks on a Friday. Good luck and see you all. Bye.